Okay, everyone, please grab their food and a drink, and please come take a seat.
University. My unofficial title is the new dean, and I'm not sure when I get rid of that adjective new, but I started here in July. On behalf of Yeshiva University and the Wurzweiler School of Social Work, the Ferkauf School of Professional Psychology, Alumni Relations, and the Counseling Center, thank you for coming tonight. It's an exciting event that's planned, the first of its kind, the first, what I hope are the beginning of many collaborations between Ferkauf and Social Work and the Counseling Center. We're talking about a difficult subject. We're talking about suicide and resiliency. And regardless of what profession you're in, whether you practice a helping profession, wherever you are, whatever community you live in, we're all affected by suicide. Could be a member of our family, could be a client, could be people in our work environment, could be our neighbors. And so listening and paying attention to this subject, while difficult, is so important because this is such a pressing social problem. There were many people involved in planning this event, and I'd like to name them, and hopefully they will excuse me if I don't pronounce their names correctly. But the planning committee deserves a lot of thanks. First, we'll thank Beth Liebenson-Paver in the back, Director of Alumni Engagement, Morgan Hager-Leibowitz, the Director of Institutional Advancement for the Graduate Schools, Leslie Halpern, Dean of the Ferkauf Graduate School of Psychology, who we will hear from in a minute, Chaim Nissel, who's on the panel, the Vice Provost and Dean of Graduate Students, Jay Swifek, who is a professor in the School of Social Work, Dalit Reichland, the Director of Institutional Advancement for Yeshiva and Stern Colleges. I saw her someplace. Yael Muscat, the Director of the Yeshiva University Counseling Center. Randall Richardson, the Associate Dean of the Ferkauf Graduate School of Psychology. I'm sorry, I said social. I'm so used to saying that. Adam Zerman, who's from Institutional Advancement, and Jack Durrell from Institutional Advancement. There's several members from the Board of Overseers from the Wurzweiler School of Social Work who I'll recognize, some for some reason sitting in the back of the room. Elaine Schott, Froma Beneroff, and Julie Kagan. And now it's my pleasure to introduce my colleague, my fellow dean, Leslie Halpern, Dean of the Ferkauf School of Psychology.
Randy, thank you for those wonderful words. And since he did all the introductions and thanking, I'm just going to second that. There were a lot of people involved in planning this, and it was one of those instances where there weren't too many cooks in the kitchen. We all worked together. We produced a really good product, I think, for today, and it's a very important topic. So again, thank you all for coming, and thank you to all the alumni who are here. It's wonderful to see everyone. I have the honor of presenting our moderator for today. And so our moderator for today is Dr. Chaim Nissel. He is the YU's Vice Provost for Student Affairs and Graduate Dean of Students. He helped establish the YU Counseling Center about 20 years ago and was director for that center for about 10 years. He's also a trainer for the American Association for Suicidology, and he's trained over 2,000 clinicians. So clearly he is an expert in this area. Throughout his long and dedicated tenure at Yeshiva University, he's been a member and mentor and leader for staff and students, infusing the importance of mental health into all areas of student life. And clearly, we live in a time where mental health is becomes such an important topic for all of us to address. I think not a day goes by where we don't hear about the importance of those who are working in the field of mental health and the importance of providing mental health services to those who are in need. Without delaying further, Dr. Nissel, and I believe you want the microphone over here.
Okay, thank you, Dean Halpern. And thank you all for joining us this evening. Very exciting to be here. First, I have couple of questions for the audience. The rest of the questions come to the panelists, but I wanted to start with you. Show of hands, how many of you are mental health professionals? Okay, the vast majority, but there are also several people here who are not, which is great. How many of you are alumni of any Yeshiva University school? Okay. Again, it was an alumni event, but it was also opened up to the community. So we welcome everyone here. I'm just curious how many alumni we got, and a beautiful showing from alumni. My final question for you is, how many people here know somebody who died by suicide? Wow. Wow. This is a topic that hits everyone. Mental health professionals, people who are not mental health professionals. It cuts across all sectors, and that's such an important topic, and that's why I'm thrilled with having this topic here and that you're all here to join us. Tonight's topic is called Suicide Prevention and Resiliency, and we will address both topics. We'll walk away with greater awareness how to protect individuals who are at risk for suicide, and we will also talk about how to best respond, whether as a therapist or a friend, when someone loses a loved one to suicide. We're going to start tonight's program by hearing from two survivors of suicide. Survivors in that they survived the death of a loved one to suicide. Following our conversation with Shalom and Sonia, we'll turn to our three professionals to hear their thoughts on this important topic. Rabbi Shalom Hammer is a triple alum from YU. He has his bachelor's, master's, and rabbinic ordination from Yeshiva University. He's the author of 4 books. He and his family have been living in Israel for the past 34 years. Rabbi Hammer lost his daughter to suicide in 2019, and since that time, he has become a strong advocate for mental health awareness and suicide prevention. He has spoken on the topic of mental health awareness all over the world and has founded Gila's Way in memory of his daughter, and I'm sure he will explain more about that later. We thank him for joining us this evening. Miss Sonia Spicer, although she has spoken to many people about her sister's suicide 3 years ago, this is her first time addressing it in such a public forum. And we thank her for being here tonight to share her experience with us. That's just to give me a chance to clear my throat. Okay. Shalom, we're going to start with you. Please paint a picture for us of Gila's first 16 or 17 years of her life, before things went bad.
That would be, first of all, I want to thank all of you for hosting me this evening, for having me here. I'm not going to take a lot of time with the amenities and the niceties, because we have much to discuss, and to then a panel of 5 people is rather challenging. It's been about 37 years, I think, since I've been in this building. It's nice to see that not much has changed. And you had said, there's 2 things I want to point out. You had said, Dr. Nissel, that we are excited to host this evening. I'm not excited to be here. I would rather not have been here and would never have wanted to participate in a panel or take a 360 in my life in terms of the focus and what my dedication is to in my life today, because it's the result of a catastrophic consequence. It is the worst possible catastrophe that someone can experience in their life. Lo aleichem, none of you should ever know, but some of us in this room do. And secondly, I'd also like to know why the 2 doctors at the end of the row over here have larger microphones than ours. But I will not take issue with that. To describe Gila, in order to describe Gila, would be an injustice, really, to describe her in a few minutes. Really 18 years of her life. She died at the age of 18. But those, the vast majority of those 18 years of her life were wondrous. Gila was an absolute social butterfly. She was rambunctious, vivacious, audacious. larger than life. She was the leader of her peers. People turned to her for advice, guidance, direction. Her personality was magnanimous, and she was extremely colorful and very, very inviting to all. I have profiled many adolescents, young people who have died from suicide, and what I have found, the vast majority of them all fit a very similar profile. And that is number one, they are extremely social. They are leaders of their peers, very sensitive, and they bear the brunt and burden of people's struggles on their shoulders, and they feel them extremely sensitively and empathetically. And thirdly, they are also tend to be impulsive and really just go-getters. And that really describes Gila in a nutshell. I mean, people who met her, anyone who met her, remembered her extremely, extremely well. She would have a very, very strong impact on those who were around her or who she met. This past Sunday night, I spoke in Great Neck, New York, and it was put together by a number of students who now are 23 years old, what Gila would have been today. And they had been in camp with Gila. We're talking about 6, almost 7 years ago. And they only knew her for 3 weeks. And yet they described the passion and compassion that she demonstrated to them and the impact that she had on their lives, so much so that to this day, they memorialize her, they embrace her spirit, and wanted to have this event for me to speak with them in order to have some connection consistently to Gila. So this was the type of personality that she was, undoubtedly a very, very impressive person.
Thank you. Okay, Sonia, please tell us about your sister, Rachel. What was her life as an adolescent and as a young adult?
So, my experience is very different than yours, Rabbi. My sister had mental illness most of her life. She had something called borderline personality disorder. She was also the most, in a room, lit up a room. I do, that's very common, I think also. An artist, a mother, the most giving person. She would give she would collect clothing, collect toys, collect and really walk up to, when she lived in Arizona, and go to homeless people lived, and would give them everything she had, pretty much. She was a very sorry, but she also had a side that was horrible. Terrible things. She did terrible things. Growing up, we had the police at our house almost on a monthly basis, just from her behavior. It was tumultuous. My sister tried to kill herself a couple of times. I walked in on one time when she was a kid. I'm about 9 years older than her. So it wasn't, it was a very, our whole lives, my parents, everything revolved around Rachel. How she was feeling, how she was doing. It was different, but she definitely was the kindest person I've ever met. Most giving too. So.
Thank you. Was she hospitalized as an adolescent?
Several times.
Several times.
She was also sent to a school in Utah before we knew what they did there. She was really hurt there, but we didn't know. It's a very sad scary situation.
Okay, thank you for sharing that, and I'm glad you included the positive memories of her and her giving nature and what she was like. Okay. Okay, Shalom, based on the description you gave of your daughter, Gila, it would seem very surprising that she would go on to kill herself. What happened?
You do realize you're asking me questions that it's very hard to answer in a few minutes, but very different.
But you will.
Yes, I will to certainly pressure of the crowd. Very different than what Sonia is describing. Gila did not suffer with mental health challenges for the vast majority of her life. She pretty much spiraled out of control as a result of really two outstanding, unfortunate events. Number one, there was a situation in camp where she was very popular, the same camp that I went on Sunday night to speak to some of the alumnus from there. And there was a young man a young man from the United States, it was in Israel, and he took her phone and wrote a text saying, I quote you, excuse me for my French, but he wrote, "I want to have sex with you." That text was sent to the entire camp. And the reason why I point this out is in my lectures that I speak about, and all those who are mental health professionals know about something which is called triggers. In Israel, we call them trigger. And triggers are things that could really throw someone into a spiral, particularly when we talk about the most aggressive climb of suicidology and suicide ideation of the ages of 16 to 26 or 24. And at that age, they're extremely vulnerable and susceptible to various appearances and various experiences. And this was a trigger for Gila. It's interesting that Sonia said about how her sister, Alea Shalom, would embrace homeless people. Gila was the same way. She would go outside and embrace, literally give hugs to homeless people. She had a very, very innocent way of seeing the world, extremely non-judgmental, at the expense of herself. And after this happened, she was judged and she was immediately dismissed from the camp because it was sent from her phone without opportunity to protest, to converse, to explain, to even say goodbye to her friends. She was sent home immediately on a train. It was made by none other than a 26-year-old who ran the camp, and he made a very, very poor calculation and decision. And this threw her into a little bit of a different search, so to speak. But really, what was most impactful, unfortunately, was the next year when she went to a Purim party with a bunch of her friends in a place called Ramat Beit Shemesh. There was a young man who she didn't know who ultimately had her come into a room. He locked the door and sexually assaulted her for over an hour. That was the obvious blatant trauma that threw Gila into a complete whirlwind, a state of chaos, degradation, debasement, embarrassment, where she was not willing to discuss and converse. And it's known with regards to trauma that the faster you address it and converse about it, the greater chance you have of both identifying it and of treating it. Well, this swelled inside of Gila for a very long time. And essentially, the steps that followed was a result of that. She was not prepared to discuss, to converse, to open, to receive proper treatment, even though we obviously, as parents responsible, we did seek treatment for her. She did go to therapists, but it was never tapping in frontally what exactly was the problem and the means of alleviating that pain. And so classically, she turned textbook. She turned into depression, anxiety, to substance abuse. And ultimately, because it was not addressed, there was an impulsive decision that she made. And it was impulsive. And I will just say this, because this is probably the most important thing, what you'll hear this evening. Excuse all my other panelists, but I strongly believe this. And that is, all of you need to know that the vast majority of people who die from suicide do not want to die. They want to live. They find themselves in a deep, dark place of despair that they don't know how to climb out of. And for that reason, they see or postulate only one possible avenue, Rahman al which they entertain. And that means that if we are capable of giving them a glimpse of light and helping them overcome this hurdle, and in Gila's case, by the way, she absolutely should be alive. It was a textbook case. And if we're able to give them that glimpse of light, we are capable of saving their lives. And that's in a nutshell what happened.
Since sounds like she was in treatment, I'm sorry, like to hear the story, and I absolutely agree with you. I'm not excited to be here. I think it's an important panel. I'm glad we're having this discussion, but I'm sad that we're having this discussion. Was she in treatment at the time of the suicide? Were there guidance that the professionals gave you or didn't give you that could have possibly changed?
Yeah, so that's the answer is that she was in treatment, and the answer to the second question was yes and no. There was much guidance and direction that they should have given us that they did not. And that's why I do what I do today. I don't want anyone to ever be in a situation where they don't know. Now, there were clear, blatant signs that Gila had with regards to suicide tendencies, and no one ever spoke to myself or my wife or used the word suicide. That's a mistake. Suicide is a symptom of an illness that exists, and it has to be addressed. It has to be dialogued and spoken about, because the more that it is, the more we understand it and the more we can cope with it or deal with it if someone is struggling with it. Just to be clear, two things I will tell you. Number one, the last 2 weeks of Gila's life, we have on our website 11 classic, excuse the word, signs of suicide. She exhibited 9 signs of suicide for 2 weeks. No one said to my wife and I the possibility of her experiencing or thinking about suicide. The day that she died, we were with her at the psychiatrist, and she was in a terrible state of stress. And the psychiatrist prescribed a basic medicine that would alleviate some of her anxiety and sent her home on the bus by herself. And she never spoke to us or said to us that she's in danger or that she's exhibiting various signs. This was a terrible mistake. And again, there was a lot of negligence in Gila's case, but for me, what's important now that we have experienced this incomprehensible loss and that we experience every day is that people know, is that people be aware and use the word so that they understand. The final thing I will say is as follows, and I normally do not say this in public, but based on your question, it's important. Gila went to a DBT therapy group in the hospital in Jerusalem, which will go unnamed. And she was part of a group of 11 young women there with 2 psychologists on staff. One of the psychologists knew her well and was aware of her situation. We had met with her a number of times. Gila was exhibiting, number one, we just got a report recently that actually there was a parent who came in with her daughter, bringing her daughter to the session, and they found Gila with her legs dangling out of the window sill on that day. And they panicked and they went to the psychiatrists on the ward and said, this is what's going on. And they said, it'll be okay. And they did not come to assess or discuss or converse. During the session, Gila approached the windowsill twice. The psychologist who knew her told her or asked her to distance herself from there. When there was a break, a 10-minute break, Gila came over to the psychologist and said, can I go downstairs to take a cigarette for a few minutes? She said, responsible here for everybody's life. It's impossible for us to do that, but we are responsible to educate ourselves. and to recognize what's going on in our surroundings. Because people, like I said, don't want to die. They don't know how to say necessarily in so many words explicitly, save me, help me. But what they're saying is, save me, help me.
Thank you. Based on that description, it sounds like Gila should still be alive today. People had done the right, I know we're not assigning blame, but there were steps that were missed. And I think that the parent education is a really important piece. And I applaud you for sounds like it's prevention through education. Sonia, you're doing great. You're doing great. Just hold the mic very close to your mouth. Obviously, the situation is very different with your sister. Seeing what you had going through so many years of seeing her turmoil, did you think that one day she might kill herself?
So, yeah, I mean, it was still a shock when it happened. She also had two very small children. We thought maybe that would stop her, but didn't. I'm just gonna ask you a question. So we did see some signs. Legally, we could do nothing. That's a problem also. There's nobody informed us, I mean, with anything. And they won't, they can't. She was 37 years old. So it's, it is the most frustrating thing ever because nobody can talk to you. Unless we took her to a judge or got her declared mentally, not be able to take care of herself. It's a very, she was still a person. She was functioning. Nobody was gonna let us do that. Rachel should be here too. This is, it's the most, it's something you just never understand.
Right. It sounds like you saw her decline and tried to intervene, and the systems did not allow it.
Listen, she made it so we couldn't intervene. She completely dropped us. She became very hostile because she didn't want us to intervene. I believe also she wanted to be, when my sister committed suicide, she left every window open in her house. Her door was unlocked. She did not, she wanted to be saved. I believe. I think she really wanted to be saved because she was the most, she would never leave every door open, every window open. She was very, she just wouldn't.
Can you share the circumstances that led up to her suicide? Like what made you think that she was becoming a higher risk? Becoming more concerned?
She became, she dropped everyone from Facebook. Well, she was very big in social media. She actually was, she didn't do anything without letting social media know first. She but dropped my parents, me, my siblings, everybody. It was interesting when she did die, people that were friends with her on Facebook, then they sent me the videos of her in distress. And they're like, oh, like where she really was, she went down to 80 pounds. She was not talking sense. She was very drugged, very, a lot of alcohol. It was so painful to watch after the fact because somebody just had sent it to me before. It's very fresh, very upsetting. Yeah.
Okay. Following the suicide.
Can I just say
Sure,
one thing, if
yes.
you don't mind, to Sonia? First of all, I should have started, by the way, saying that I'm so sorry for your loss. Because I know that I appreciate when people tell me, and we have many conversations, and it's important to recognize that. So I am so sorry for your loss because I understand it. But what I will say is that one of the things that I'm hearing from you, and correct me if I'm wrong, please, is that you and members of your family, and this is in no way to place guilt or blame, but that you too were not necessarily aware of some of the signs and indications. For example, one who knows the sign of someone who is contemplating suicide knows that that's one of the things. Asking any, but I'm demonstrating how important it is. Now, no, not the guilt, but how important it is to realize it's that
Wish I
we
did.
didn't know the signs. We didn't know
Yeah.
these are things that need to be spoken about.
Right. Yeah, listen, it was, I wish I did. You're right. You're right.
Okay, take one more question for each of you. Shalom, what advice would you give to someone who is sitting alongside a loved one as they're contemplating suicide? They're suicidal. What would you tell that person to do?
Well, I mean, when you talk about someone if you're fairly sure that they're contemplating suicide, I mean, that's what we give seminars about, how to respond to someone like that, what to say, what to ask, and what not to ask. There's two things, actually, let's say four things. Rabbis never say one thing, so I'm going to say four. Number one, it's a myth, an absolute myth, that one should not use the word suicide or it will plant the idea in someone's mind. It's totally bogus. It's not true. Anyone who's thinking about suicide is thinking about it before you said it, and anyone who's not is not going to think about it because you said it. So that's number one. Number two, someone who's contemplating suicide needs to be asked one thing. The most important thing you have to ask them is, are you thinking of suicide? Are you thinking of killing yourself? You have to ask that question. And the reason why is because what you're doing is you are alleviating them of a burden from their shoulders that they know is taboo. They know it's wrong, but they also know that they have no one to speak to about it. The moment you ask that question is the moment you say, I am prepared to engage in dialogue with you. I'm here for you. I don't understand what you're going through, but I understand that you're going through something. And so you can talk. And that's the most important thing, because everyone needs to know that there's someone there for them. Otherwise, they can convince themselves that there's no reason to continue. The third thing is, and this is the general rule is validation and empathy. Validation means that we demonstrate to them that we understand something about them. Do not say to someone who's in crisis, I know exactly what you're going through, because it's not true. You don't know what they're going through. And don't say to me as a griever or bereaved, I know exactly the pain that you feel, because you don't. What you should say is, I know and I see that you are experiencing distress and pain. I don't understand it, but I do feel that you are in that position. Therefore, empathy, I would not and am not going to leave your side, because I'm here for you and I will be with you every step of the way. If you say that, you have to mean it. You can't say to someone, I'm here with you and will be with you the entire time, and then answer your cell phone, or then walk out the door and say, I really got a bus to catch, maybe tomorrow. Can't do that. So there has to be validation, truth, and honesty.
Okay, thank you. Sonia, I mean, we know that Shalom is here on his tour around the world, speaking, inspiring, educating. Can I ask what prompted you to agree to speak here tonight? Very brave to share your story. We appreciate it, but why are you here tonight?
So I just want to tell Shalom I had that in my notes too. I have my index cards about, that. You did. So, my good friend Lauren Leibowitz, best friend, knew what I went through. And she brought this to me. And at first I really was hesitating. And then she mentioned Dr. Hammer, Rabbi Hammer, you're a doctor now. I would watch Rabbi Hammer's videos on YouTube. Very inspiring, very meaningful. He was somebody that spoke my language, spoke about how I felt. And it was very a chance to be with him and speak with him. Okay.
I would have bet you for coffee.
And now you tell her.
Right. But I did this also as a part of the healing process for myself, which it's a long recovery, it's a long road. But also I found it very hard to find support in the terms of speaking with people that have gone through it. I was part of, a lot of support groups online, but it was very general. I really didn't relate to a lot of them. I mean, some of them, but their daily lives were very different than mine. It was a very difficult, if that could be made aware that there needs to be more support because people are struggling. And, that's really.
Okay, thank you. Okay, so thank you to both of you for sharing your stories. They're so difficult and so meaningful, and I'm sure everybody is hearing and learning from them to hopefully help prevent suicides and tragically, if there is a suicide, have a better sense of how to respond and be supportive. May this program be a zechut, the merit for both Gila and Rachel. But as we are kind of moving over to our three professionals, I'll be asking them questions, but if anybody in the audience has questions, you can write them on index cards that are passed around. And at the end, we'll collect them, so hopefully we can have some of your questions as well, which could be for anybody sitting up here. Except for me, I'm the moderator, I don't have to answer anything. Okay, so we have Dr. Block Elkobi, who is an assistant professor in the clinical PsyD program at the Ferkauf Graduate School of Psychology and an associate clinical professor at Mount Sinai Behavioral Health Center. Her research focuses on the intersection of suicide prevention and psychotherapy. There's a longer blurb in the handout. Feel free to read that as well. It's done a lot more, but just picked up on a couple of highlights. We also have Dr. Alper, who's the assistant director of the YU Counseling Center. She served as a therapist and a supervisor at YU Counseling for 8 years. She's also served as its outreach coordinator and has overseen the training of countless externs and interns in the counseling center. We also have Dr. Flaherty, assistant professor and chair of advanced clinical practice at the Wurzweiler Graduate School of Social Work. She has over 15 years experience working with adolescents who engage in high-risk behaviors. Dr. Flaherty Dr. Flaherty's research interests are in the areas of clinical practice with a focus on innovation and implementation of evidence-based practices for mental health clinics serving high-risk youths. I'm glad you're all able to join tonight. I'd like to start with a question. We'll start with Dr. Blacko-Kubi. Was there anything that Shalom or Sonia said that you'd like to comment about, reflect about, or more specifically, does it relate to any of the work that you've done, things that you've seen?
Sure. First of all, I want to react as a human being who just heard you talk about your loved ones, and I want to say how sorry I am to hear all this pain, all this that you had to go through. Indeed, I can only imagine or try to imagine or try to understand how you may feel. I wish you didn't have to be here tonight. I wish you were in your normal life and that you never went through this. And with that being said, I really appreciate your effort helping in suicide prevention, in education, helping us professionals hear these stories and thinking about how can we integrate this really important information that you are kindly and generously sharing with us to improve our research. I will add that there are several things that I heard indeed in what you have said that were very, very related to several important areas of research and one that I am directly involved in. You mentioned several warning signs or short-term risk factors, as we call them, several processes, especially psychological processes, that are very much part of acute suicide syndromes or acute suicidal states that are being researched right now. One of those acute suicidal states, the one I am personally researching that was developed by my collaborator before I joined him, Dr. Igor Galinker, is called the suicide crisis syndrome. And I could just hear what you said and check the symptoms of the suicide crisis syndrome, which is an acute suicidal state involving a sense of entrapment, a sense of intense pain, having a sense that we are stuck in a problem that is absolutely intolerable, but also having absolutely no other way out of this problem. And this acute suicidal state very often comes with additional symptoms, one of them being an acute affective disturbance. You talked about emotional pain, you talked about depression, extreme anxiety. It also comes with social withdrawal that the two of you mentioned, this idea of not sharing directly with loved ones, sometimes completely withdrawing socially, sometimes not withdrawing from everything, but not sharing anything of what's happening, a sense of extreme tension and hyperarousal, extreme anxiety with sometimes panic attacks. And Sonia, you also said she wasn't thinking straight, a sense of what we call loss of cognitive control, a sense of having ruminative thinking and having a hard time thinking and making sense of our experience. And so, Rabbi Hammer, when you talked about asking about suicide, that resonated with me quite a lot. And I would add to this that in addition to asking our patients about suicide, unfortunately, we also know in the literature that quite a lot of patients will not always answer in a straightforward manner, which doesn't mean that we shouldn't ask, absolutely not. But maybe the other thing that I'm also working on in my research would be to add strategies to destigmatize suicidal thoughts. The way I personally go about it in an intervention that I am developing is to try to talk about suicidal thoughts as something that our human brain does when we are in this state of entrapment. You mentioned the word symptom. We could also talk about it this way, but trying as a general kind of almost cultural thing to talk to our patients, but to us as human beings, to everyone, about this is what happens to us in certain conditions. And if we could talk about it, hopefully we could also recognize it and not repress it. One of the things that we also see is that patients sometimes don't talk about it because they don't want to think about it. Once they feel a bit less on once the sense of the suicidal thoughts are a bit less pressing or urgent, sometimes we ask them and they will say, no, they felt differently 5 minutes ago, but they will think, no, that was just because now I'm feeling a bit different. So a lot of what you said resonated quite a lot, and especially this idea of the importance of education about these warning signs. We calculate the suicide crisis syndrome. There are other syndromes that have been researched by other groups that are very similar, but also this idea of destigmatizing and educating all of us as human beings, not just clinicians or patients, but all of us about what we do as human beings in acute states of entrapment and stress.
Thank you. Thank you. Dr. Alper, is there anything you would like to respond or about something they said, or more generally?
Sure. So I echo Dr. Blackwell-Kupi's sentiments. I appreciate so much that you're here. It was very, very moving to hear both of your stories. And I can only imagine that it is challenging to do something like this. So I think we're all very appreciative that you are. The thing that really jumps out to me, and it's really a beautiful thing, is how in spite of, or maybe because of what you've gone through, and you know, the depth of how painful that has to have been, your desire to make meaning out of it and turn it into something that then you can pass on and hopefully either, you know, decrease the likelihood that this happens in another family, or give some comfort if unfortunately it has. And we see that a lot, that people having gone through very challenging experiences, sort of as part of the process, look for a way to make meaning out of it. And I think we're just, you know, so fortunate that this is how you've chosen to do that.
Thank you. And Dr. Flaherty.
Yes, I have a few things. Well, first thing I want to say also, thank you so much for being here and sharing your stories and starting the dialogue. I really think communication is so important, and to help reduce the stigma. It sounds like you were really failed by the mental health industries, both of you in different ways. And we have an obligation to educate the next generations of mental health providers to not be fearful of having these conversations. Like you said, saying the word suicide or talking about it or normalizing it will not, in fact, have a client act on it. We have the statistics. I can share it with you to help make your argument, but it doesn't, no client is gonna say, you know what, I've never thought about doing that. Now that you said it, I will. It's not gonna happen. And we have to make sure that everyone's comfortable having these dialogues, because asking the questions will save lives. Your daughter never should have gone out alone that day. That person should have been trained enough to say, I'll come with you for a smoke. These are the things we need to do, and to understand. Unfortunately, with mental health, we learn from our mistakes, and hopefully we as an industry can learn from the mistakes of others and to better train the next generation. And having the communication around stigma, because it is stigmatizing not only to be the person who's having suicidal thoughts, but the reminding family members. You're saying you have a hard time finding support groups and they're hidden, and they shouldn't be. They shouldn't be. There shouldn't be so much fear and regret and shame around these things. We should be able to come together as a community and as an agency and as a support group to rally around and help you. So thank you so much for being here and to really open up the conversation, because it will save lives.
Okay, thank you. Dr. Alper, in the counseling center, how does the counseling center respond when you encounter a student that is at very high risk for suicide? Are there any protocols you follow? Is there a particular type of intervention that
Sure.
you use for assessment or intervention treatment?
Sure. So we use something called the CAMS, which is actually for assessment, but it's also a general way of thinking about suicidality, and it also informs our treatment. So the idea with the CAMS is that, in a nutshell, it is meant to be very collaborative. So together, the therapist and the patient, or the student in our case, go through together trying to understand what the student's level of risk is. And in that way, it's not adversarial. It's not, you know, I'm the clinician and you're the patient and you're sick and I'm well. It's a very nice thing about it, actually, that one piece of it is that when a student, a patient identifies that they are having serious thoughts of suicide, you take a break and the clinician moves. So typically, you know, we'd be sitting some version of across from each other. The clinician actually moves and sits next to the client. And the idea is, okay, now we sort of stop and we shift the dynamic, and now I'm in this with you and we're working on this together. It's just a very nice like physical gesture, I guess, you know, what we're trying to communicate to the students. The idea, like I said, is that it's very collaborative. The goal is to really try to understand together with the student, what are the term they use are the drivers? What are the things that are really, or you might say the triggers? What are the situations? What are the thoughts? What are the things that are driving the suicidal thoughts? And then once we understand that, then we can progress into the treatment. But the idea is that the whole process is meant to feel very collaborative, very supportive. And I think I'm going to echo what a lot of people are saying, that a big part of it is just being willing to talk very openly about suicide. A lot of the times the students that we see are having thoughts and feelings and fears that they really feel that they could not possibly bring up with anybody else, that it'll scare people too much, you know, everyone will freak out, and they just have this sense that like no one can really handle what's going on in their own minds. So we try to really set the tone very quickly that in this session, in this space, you know, we won't be scared off by anything. You can say anything, we'll work together to get through this. And you know, we say it, we name it.
Okay, thank you. And a follow-up question though, when a student is talking about imminent plans, they've already researched it, they already are thinking about what they would do to either hurt themselves in some way or to kill themselves. Is it still following the CAMs and
Right.
telling them to come back next week for another session?
Of course not.
What would you do in the more extreme situation?
Right. So the CAMS is designed to try to avoid hospitalization when possible. That, you know, that is definitely a piece of it. Of course, unfortunately, there are times where there's really no other choice. When, you know, the person really has a plan already, when we really feel that the threat is imminent, then of course, you know, all of that sort of out the window, and then a lot of other things come into place. If they're a student on our campus, we might, you know, if they're not in my office at the time, let's say, we might alert their RA, their GA. There's a lot of levels of support. We have, you know, people always in housing that will reach out to them, let's say it's the middle of the night, you know, those sorts of things. And of course, when we need to, we bring them to the hospital.
Thank you. Okay. Okay, so Dr. Blacko-Kupi, the research you mentioned around suicide, there's this syndrome that you've been talking about, which I know that the DSM was talking about getting that in. It's a potential new syndrome that you're researching. What about the treatment part of it? Are you involved in looking at psychotherapy or treatment for suicidality as well?
Sure. So the suicide crisis syndrome was proposed to DSM with that thought that instead of having each institution that comes up with their own suicide risk assessment, which typically involve those questions, which are very important, but in our opinion, based on the research, not sufficient, absolutely not sufficient. And I think that you talked a lot about the other signs that should be crystallized in our understanding of suicide states. Both so that we can see the warning signs, but also so that we can educate everyone, our patients and all human beings. When things like this happen, this is what you should understand that's happening with you. So it has been proposed to DSM, and in addition to that, that's correct. I've also been working on developing an intervention. CAMS is indeed a wonderful intervention. What I've been working on was when I was a supervising psychologist on an inpatient unit. And what I've been working on was trying to think about what are the main obstacles to help patients work with psychologists when they are in these moments of suicidal crisis. And what I found based on the literature and my experience was that stigma was a really important one. Another one was clinicians' emotional responses. We are human beings, and when someone is deemed at high risk for suicide, we are afraid, and we have all kinds of emotions that come up. And so these emotions can also have an impact on our patients. They can sense that we don't want to hear about their risk, we don't want to hear about their thoughts, because then we're going to be like, what do we need to know? What do we need to do? Sometimes it's a bit comfortable to, if they say no, to just believe them and not move forward, for example, ask further. Or sometimes if they see in our facial expression that we become tense, then maybe it will be a signal, similarly to what you said before, actually, maybe I'm not a safe person. we cannot control our facial expressions. This is something that's very difficult and that requires a lot of training. So one of the elements that I included in this intervention comes from another area of research in psychotherapy research called alliance focused training. And those are techniques that are helping clinicians really work on their emotional response, their awareness of their emotional response, as well as tracking very closely the patient's emotional response. Is the patient withdrawing just a little bit? Do they provide a bit of a short answer that seems to be different from the type they answered just before? And when that happens, we work a lot on pausing and trying to understand what is happening in the moment. So those are some elements of this treatment. The other elements, to kind of go back to what I was mentioning about stigma, are very much about not just talking about the drivers, even though that's very important, but also developing a model of underlying vulnerabilities, stressors, how those stressors bring us into a mode where we think a certain way about ourselves and others, and how we end in the state where we feel that we're trapped and we exhibit the suicide crisis syndrome symptoms. The hope with this model is in some ways normalizing, so that patients will feel, oh, there is a model. A lot of people go through this. This is something that so many people go through this. It doesn't mean I'm crazy. It doesn't mean I'm hopeless. These are suicidal thoughts that emerge in my mind, in my brain, because for a lot of people in the world, this is a progression that happens to them, with the hope that that will help them. It's a short intervention that I've developed in an inpatient setting. And the hope is that with this type of intervention, patients then have their individualized model that they create with their clinician. And when they get out of the inpatient unit, the hope is that they can continue working on this, hopefully with this new understanding that they are not crazy. They are normal human beings under some circumstances.
Dr. Nissel, can I just ask, I'm sorry, that's actually, that's fascinating and incredible, that work that you're doing. I would be very interested in learning more about it. I don't, you would have to correct me if I don't know if that exists in Israel, that model, what you're describing. Is it already public, is it already publicly being used in medical models, what you just described?
So the suicide crisis syndrome has been used in a lot of settings, including in Israel, at the Schneider Hospital, where one of our collaborators is working. The intervention that I have developed, that I'm working now on a first validation study, this has not been proposed yet, but I do have a colleague who is interested, potentially including it at the Geha Hospital. So
Really?
I hope that.
Is that Zaltzman?
No, the colleague is in the US.
Oh,
And
okay.
she is also affiliated. Yeah,
That's fascinating. It just brings to mind, just very quickly, I'm sorry, doctor, that I'm taking your time, but I remember as a young rabbi, and I still consider myself a young rabbi, but I remember having the task of going into the hospital to visit the sick. And no one prepared me. When you walk into the room, you know, you're all gung-ho and you're going to save this person and help them feel better and give them then you walk in and you're like in shock by the way they look. And all of a sudden you are swallowing every word that you're saying, and you just you can't relate to them the way you had thought you were going to. And that's a physical manifestation. What you're describing is fascinating as a mental one. The ability, the capacity to speak to them
even when they're sharing their deepest, darkest feelings with them. Dr. Flaherty. I was practicing how it was spelled, not how it was pronounced. Okay, Dr. Flaherty, your research with high-risk adolescents, what do you see in high-risk adolescents? What types of behaviors?
So a lot of my research, and part of the reason why I'm up here today, specializes around non-suicidal self-injury and the overlap between self-harm into suicidality and where that line overlaps and where it doesn't. Often non-suicidal self-harm is a symptom of suicidality and can lead to suicidality, sometimes not. And so it's really interesting when we have these adolescents who are self-harming.
Can you just explain what self-harming is?
Sure, I will get there. Usually, sorry, I'm gonna get graphic for a second. I'm really sorry. Only way I know how to do this. But adolescents often will turn their pain against themselves when they can't regulate emotional pain. They will cut, they will carve, they will burn, they will, usually that's feminine movements. Masculine will punch walls, bang their heads, get into fights a lot, which is a more socially acceptable male role, which is why we have more female self-harmers. I'll get off that high horse for a second. But anyway, this idea that they cannot manage the idea of emotional harm, emotional pain doesn't make sense. So they'll turn that into physical pain. They'll cut, they'll carve. And the idea of seeing blood and seeing the injury will make sense to them with the pain, and it'll feel like a release. Now, this gets very close to suicidality, where I can't handle this anymore. I'm going to go more extreme. And often I'll have clients and we do the assessment and we have the conversation, which is really important. And we can talk about the details and we can talk about the nitty gritty. And I agree, we can get emotional. And it's going to show on my face. And it's going to show on my face because I care about my clients, but we're still here and we can still talk about it. And with that, we can move into the suicidal assessment is where's the line? And very often I will hear from my teens that, well, I carve, but I carve here on my leg because I know I won't die. Or I'll clean the instrument so I won't get an infection. And it's not about hiding it, but it's about getting to that point where they won't end their lives. That's not to say that if the trigger gets more intense, that the action won't get more intense as well. So it is within the same realm, and it's the same conversation. We have to have the conversation. We have to have the assessment. We have to sit in the room with them and have the conversation with their parents, what to look at, what not to look for. Do you put away all the sharps? Is that helpful? Is that meaningful? Do I send them to the hospital where they're going to be evaluated and released because they're not suicidal? Right? They're going to tell you that, so what is the intervention? And it starts with communication and it involves the family. We must always involve the caregivers and the family because clearly this teen is saying, I can't do it alone. I can't do it alone. And as much as I want to be there for them, I'm not there. And who's there when I'm not? Usually the parents or the caregivers. So we bring them into the conversation around safety planning in a meaningful way, not just, call your buddy. No, what can be meaningful for you in those moments? What else can we do? And again, it's this really important conversation about being human and being there with them and saying, I see you. I feel you. I may not understand. I may not have been living this experience, but I'm here with you now. And I care about you. And I will see you next week. And text me if you need me. And call your mom if you need them. I don't know if that answered your question, but I'm sorry. That's where my line of research is around intervention in that line of non-suicidal self-injury overlapping into suicidality.
So even when, let's say, cutting is considered non-suicidal self-injurious behavior, it is in some respects preparing the person, making it's increasing risk for them,
absolutely,
increasing capability.
And for some, it remains there. And that is a technique and a behavior they can use to manage the intense emotional responses. And we will, of course, take deep dives into psychodynamic therapy and repair that, and some CBT, emotional behavioral responses, about why that's not appropriate. And for some, it stays there. For some, that's a first step. And again, the DSM is quite behind the times. Self-harm is not a diagnosable disorder. Self-harm is still just a symptom of borderline personality disorder, which becomes a large issue because you can self-harm without having borderline personality disorder. So I have to find some other diagnosis for you to fit in. And it's really becoming complicated, but we have petitioned the DSM to add self-harm as its own category.
Okay, so I have one more question on this topic.
Oh, please, I'm happy to do that.
How do you coach parents? What do you tell parents to do when they see their adolescent or a young adult cutting or harming themselves some other way?
Well, again, the first thing, we're human and We're gonna have the conversation. I'm gonna allow space for the parent to be scared, to be angry, to have whatever that emotional response is, especially in my office where it's safe and not with the adolescent present, because that's not gonna be helpful. So they're gonna assume their parent is going to be angry and sad and emotional. So let's be emotional with me and not your already triggered adolescent. And then we can come up with a plan together, and I'll provide psych ed and emotional responses, and we'll come up with a safety plan that makes sense for tonight as well as in the long term. That answer your question?
Okay, yes, thank you. Dr. Alper, I know the Counseling Center does a phenomenal job in terms of treatment. I know you also sometimes get friends who are concerned about their friends. They may have a friend who is talking about suicide, who might not be imminently suicidal, but it's still difficult to have a roommate or a close friend talking about suicide, or a friend who has borderline personality disorder and keeps you on the phone until 3 a.m. and says, if you hang up on me, I'm going to kill myself, things like that. So do you deal with friends that are struggling because, like a secondary effect, they're struggling of how to manage and help their friend? They want to be good friends. Our students are wonderful. Most of you are alumni, so you know that, right? But our students really care about each other. So what advice do you give them? How do you help the roommates and those that are in the proximate to the one that's struggling emotionally?
Yeah, so we do see quite a bit of that. And it is partly, as you said, because our students really are compassionate and they're good friends and they really want to be good friends and want to be supportive. It's also because they often live together. So a lot of times the roommate is seeing stuff that's going on that no one else is seeing, that the students' parents don't know about, that there's no reason that their teachers would know about. These students are often not even known to us yet at the counseling center necessarily. So a lot of times the roommates and the close circle of friends, they're sort of the first ones to really see it. And they carry that burden also of feeling like, I know this, now what do I do? So you mentioned borderline personality disorder and you mentioned suicidality, which are different, obviously, but in both of those situations, you know, what they have in common for the friend is there's a tremendous amount of fear. There's a lot of worry. It's a tremendous burden of feeling like, what do I do? They want to help their friends, obviously, and they feel like they need to heal them a lot of the time. And then another piece of it is that very often they've been sworn to secrecy. So they also have this very heavy guilt of, you know, I feel guilty if I'm not telling someone because I need to get them help. I feel guilty if I am telling someone. And they've said to us, you know, I don't know what to do. Now I'm telling you this, but now if she knows I told you this, she won't trust me anymore. And I'm the only one she trusts. So now if she can't talk to me, now she can't talk to anyone. So a piece of it is just sort of letting them air all of that and, you know, giving them space to sort of unburden themselves. And then we try to help them understand what they can do to help their friends, but we also try to help them understand what they can't do, because there's both. We want them to be supportive friends, which is what they want also, obviously. But a supportive friend is someone who is, you know, open, available to listen, and a non-judgmental ear, and who wants the best for them, and who's compassionate and who's empathetic and all of those things. But our students are not equipped to act as therapists, right? They're not therapists, and they can't have the impression that it is on them and it is their responsibility to keep their friend safe, because it's just impossible. In particular, when we see students whose friends have borderline personality disorder, or we think are exhibiting symptoms of borderline personality disorder, a lot of sometimes there's sort of this additional layer of confusion. It can be very challenging to have a relationship with someone who has borderline personality disorder, because a lot of times those relationships are very intense. So they can be intensely good and they can be intensely bad, and those switches can come quickly, and it can be very, very confusing. So we sometimes see those students who are just feeling very, very stressed by not knowing how to manage this relationship. So again, we try to help them understand how to be a good friend and how to remain a good friend and how to be compassionate and how to remain a support, but also how to create boundaries that are going to make it so that they, you know, the one who's coming to us, can live and can you know, be okay through this, and also boundaries that are going to ultimately help the friend that is struggling. And then finally, I should say that, of course, we very strongly encourage the students who come to us to get their friends into treatment. So, in the context of the college counseling center, we have a lot of ways that we can try to get that to happen. Of course, they can suggest it to the friends. We can suggest to them that they go back to their roommate or friends and say, you know what, I was just at the counseling center. They're so nice, come with me, and bring them over. So we have sort of like a lot of layers of support, and because they're often living in our campus, we have a lot of maybe points of access that we wouldn't have otherwise. And then, of course, if the threat really is imminent, then confidentiality and all of that is obviously out the window, and we'll intervene more aggressively to keep them safe.
Okay. And when you say out the window, you mean that you do what you need to keep someone safe.
Exactly.
Okay.
Like all yes.
Right.
Meaning I'll try to explain to a student, that when they come to me and they're talking about a friend, our conversation stays between us, as does anything that gets said, in the therapy room. However, if I find out that a student is at imminent risk of harming themselves, then, of course we have to act.
Okay. Safety first, and
Yes, exactly.
okay. Dr. Blanco-Kubi, how would you advise someone who has a loved one, they're trying to convince them to get treatment, to go for therapy, they're not imminently suicidal, but they're at risk and they're in a lot of pain, and the loved one is just not interested. I don't believe in therapy, I don't believe in medication, I'm fine, I don't need any treatment, and the friend is coming, or loved one, family members coming to you. How do you coach them through that?
That's a very hard question. It is very hard because there may be a lot of factors why someone would feel that they don't want to go to therapy. The first one that comes to mind, obviously, is that they may live in a culture where going to therapy equates being crazy, being a problematic person. Stigma is very important in a lot of different cultures. That's one that comes to mind. Another one that comes to mind is that they may have been in treatment and had bad experiences. When I was talking before about patients who are not telling us that they have suicidal thoughts very often, and the literature talks about this and based on experience as well, 70% of them do not, because they do not want to be coerced in treatment, and especially in psychiatric inpatient treatment. So I think that the first advice that I would give to the person, maybe I would give them two. I'm not a rabbi though, Rabbi Hammer, but I will give two anyway.
Thank God. Right.
Yes, I'm happy to forward the literature, but oh, sure. Among patients who said that they concealed suicidal ideation from their provider, in the literature, it seems that it's more or less 50%, in some cases more, who do not disclose to their providers that they experience suicidal thoughts, especially active suicidal thoughts with intent to act on those. Among those who do say that they were hiding suicidal ideation from their provider, 70% said that the cause was that they didn't want to take the risk of being forced into treatment. In particular, they didn't want to be coerced to go to an inpatient psychiatric unit. Most likely because they were in a psychiatric inpatient unit before, and having been a supervising psychologist there, it is a very difficult experience for a lot of patients who very often do not want to take the risk of being sent there once more. So with that in mind, to go back to your question, I think that the first advice I would give them would be to try to talk. Not so much to talk, to have a conversation, I should say to listen. To talk to the person, it's funny that when I want to say to listen, I keep saying to talk. To have a conversation where they do not talk, where they listen, where they try to understand and get into the person's head, in that sense of trying to understand how do they see the world, how do they see their relationships. Hopefully that as a first step, with the assumption that if this person is in a state of suicide crisis syndrome, or whether, no matter how we call it, suicidal mode, or whatever it's called, by other research groups, the anxiety is such in these moments that being with someone who listens, hopefully will already have an effect of co-regulation and should already decrease the likelihood that they will engage in a suicidal behavior in the very short term, in the immediate term. So that would probably be the first advice. And then I would also encourage them to go to therapy themselves so that they can process, because it's very difficult to be with someone either who has a personality disorder in the family or who is suicidal. We are going to be triggered in ways that we may not have imagined before. And in those moments, it can be incredibly difficult to stay regulated and to help the person. So those are probably the first two things. And of course, I would ask many more questions about, what is going on, and let's assess together where they may be at.
Okay, thank you. Thank you. Dr. Flaherty or Dr. Albert, do you have anything to add to that about how to coach somebody who's trying to get their loved one to agree to therapy?
Yeah, no, I definitely agree. The first thing is to have the conversation and understand what the hurdles to therapy is, whether it's stigma, if it's cultural, if it's, and if we can just overcome any of those hurdles easily, especially with introduction of telehealth, does overcome many of those hurdles. And then I like to equate it to working out with a trainer. There's always parts of us that we can do better. That doesn't mean that you're completely bad or no good or diagnosable, but we can always do a little better on ourselves. Go to the gym, we can lose a little bit of weight. Go to therapy, we can work a little bit on our mental health and just kind of take away the fear of they're going to diagnose you and hospitalize you, and that's going to be the end of it, and everyone's going to know, and get rid of some of the stigma. It's just about working on ourselves and getting a little bit better emotionally, and kind of try and take away the stigma in that way. And maybe have the conversation of, what do you think therapy's like? Have you been to therapy before? What was that experience? Have you, if you're going to a new therapist, maybe we should do better at finding you a better connection, a better therapist for you. Not that there's good and bad therapists, but there may be a better one for you, and try and take away some of the stigma that way as well.
Okay, thank you.
I would just add one thing to that, which I very much appreciate the things that you said, and I very much appreciate what you said about trying to put yourself in their shoes and like you said, talk less and listen more, which we probably could all do. The only thing I would add is that sometimes I think that the, whatever it is, relative friend that we see is very understandably stuck on the idea of getting this person into therapy, because they understandably need to get them into therapy. And what we would try to help them do is to not let the relationship become only about that. They should be in therapy, and you should try to get them into therapy. But if they're not, that shouldn't be the only thing you can talk about. You don't want to destroy a relationship by making that one point, the only thing you can talk about. You don't want it to be adversarial. So try to maintain all the other pieces of the relationship, still go on walks together, still do things together, still let, be a sounding board for them when they need it, without getting stuck on this, often what they feel is their responsibility to make this happen.
Can I add one more thing? I'm so sorry. There's a metaphor I like to give my clients if their first time to therapy that I think could be helpful here. And it's like this. I just equate what we do to the more medical professions. If you fall and you skin your knee, a lot of times we'll just stick a Band-Aid on it and be on our way. And sometimes that works. Sometimes that doesn't work, and you need more medical attention. So maybe you go to a doctor or a clinic and they have to look at it. Maybe you need stitches. Maybe there's something else going on, right? Same go with emotional injuries. Sometimes you can slip and fall, put a Band-Aid on it, do whatever technique you've always done, and that's enough. Sometimes that's not enough, and you have to go to a mental health provider. What happens when you get there is the same thing with a medical provider. They're going to take off that Band-Aid, and it's going to hurt. They're going to get in there and clean out all that rubble and dirt, and that's going to hurt. But it's all for a purpose, and the purpose is to clean out that wound and to let it heal. And then what's really cool about a healed wound is a scar. And scar tissue is stronger than regular skin. So you can take that injury and those techniques you learned in therapy. You don't have to be there forever. Once you're healed, you're on your way, but take those techniques and use them in other parts of your life. And then later on, if there is something else and you fall and you have another type of injury and these Band-Aids don't work, you come back. But it changes the way we look at therapy sometimes. So that's a metaphor I use with all of my new to therapy clients. So take it, use it if it helps.
Okay, thank you. Thank you. I think it's a great metaphor. Okay, so I have one more question for the panelists, and then we're going to open it up. People can write down your questions on index cards. Somebody will be passing around to collect them. Where is the field of suicide prevention heading? What lies ahead? Where can we expect to do better on? What do we have looking forward?
Who's the question for?
Yeah, you have the mic, so go ahead.
They have one too. They have a bigger mic. Did you say?
What do you think, Dr. Blacko-Kupi?
That's a really good question. Well, obviously, we're not doing so well. I think that the two wonderful people over there who have come to talk to us today have reminded us this kind of very painful reality that we're not doing so well. There are a lot of ways in which we need to improve. Obviously, given my area of research, it is my hope that once we can identify those psychological processes and warning signs better and make them kind of general knowledge for all, we can help ourselves, human beings. I don't like to say us, professionals and patients. We can help ourselves, human beings, reflect on these processes as they occur so that we realize, I may be heading toward a suicidal crisis soon because I can identify that this is what's happening with me. Well, that's one area. Another one is access to services and access to good services. It was heartbreaking to hear what you mentioned today. In both cases, in one case, the person who was in treatment was receiving DBT, considered the gold therapy or the ideal treatment for these type of problems. And here we go. And I can only imagine that a lot of places are just working very hard. A lot of providers have so many patients that they cannot even think themselves logically. They are themselves in states of crisis because they cannot do the amount of work. And having been working in a hospital setting, in New York, I know how it is. I imagine that Israel is probably not better, unfortunately, maybe worse. So I would say that that's also something, access to services, access to good services, and developing additional interventions, trying to see where do we fail? What are the areas? Are there certain types of personalities, certain types of what we call suicidal phenotypes, certain categories of individuals that we do not catch, or if we catch them, we're not able to help them properly? So I'm afraid that there are still a lot of challenges ahead.
Thank
I'd
you.
like to, can I
Sure.
address something, because it's important, as the doctor just said about Israel. I have the most experience in Israel, so I don't know that much here. First of all, just listening to all three of these doctors here, I'd like to encourage all three of you to make Aliyah, to move to Israel, and I will find you, all three of you, jobs in the mental health world. I think all of you would bring a wondrous amount of experience and professionalism to Israel. So please follow us. My flight's back on next Wednesday. I can book your seats and we can get that done.
I just got my job at Ferkauf and I truly love it. So
in front of the dean over here. But really, kudos to all three of you. But what I will say is that my experience, and we at Gila's Way in our organization, we're not mental health professionals, and we do not entertain to ever be. We make that very clear to people who contact us, okay? I do not administer therapy. In fact, one of the things I think that one of you mentioned at some point, I don't remember who, I am not such an altruistic, righteous person. And I'm happy if all of you argue me with that, but I largely lecture and speak and threw myself into this world because it's therapeutic for me. And that's a large part of it. But having said that, what we do offer in Gila's Way is consultations. And what happens is that when a family, especially parents or a significant other, is involved with someone who is really in a state of chaos, the parents and the relative and the colleague and friend are also involved and become chaotic. That's why, first of all, I'm not sure, and I don't envy any of you in terms of how you deal with the roommates of these people, because one of the things that these roommates need to understand is that it is not their responsibility to administer therapy or to help them along, and perhaps the only solution is to break them up and to remove this person from the room. I don't know. but it would be terrible for some of these roommates to experience or to see some of the things that could possibly go awry and to feel that responsibility. So I don't know, that's something that I'm dubious about and makes me nervous. But having said that, when a person is going through these struggles or their significant other is, there's a tremendous state of chaos. And what we do is we provide a consultation service to get them to first base, not the person struggling, the parents, the caregiver, the person who's with them, just to get them to first base. And we identify what's going on, and we work with 2 psychologists on house who, it's not just from us, but we work with professionals to be able to get that done. Having said that, what we're realizing, and this is something that I hear from people who call me from the United States, South Africa, Israel, certainly, the United Kingdom, absolutely, even Australia, where nobody lives, there's also, even Australia, which is, by the way, considered the creme de la creme of mental health facilities. I was there lecturing in Sydney and Melbourne and Perth, and I couldn't believe the questions I was getting. That they really, I was very, very taken aback and unpleasantly surprised. But my point is that the world over is becoming a much more chaotic, challenging, inundating place for youngsters to live in. And with that, there is an expansion, whether we like it or not, or whether we should label people as being needing mental health facilities or whatnot. There's just not enough mental health care and capacity in any of these countries. And you said it, Dr. Flaherty. You said, oh, I'm going to send them to the hospital. I know exactly what you were doing. I'm going to send them to the hospital only to be told, you're not suicidal, go home. You know why they do that? Because there's no room. And they don't know what to do with them. So that's just all over the world. And my point is that what's happening in Israel, and I know it's happening here, because last night I spoke here in Yeshiva University, and there was a club called Active Minds. Active Minds was started by not Yeshiva University, it's all over the campuses throughout the United States. And the reason why those efforts are starting is because they are saying we need to take mental health into, not that we're, rejecting professionals, but we need to take mental health into our hands. We need to find other means, other sources, other social stratospheres that we can allow there to be solutions and help in that sense. So as far as what you're asking, I think that's what I see happening a lot in the face of mental health in Israel.
Okay.
Sorry.
Thank you. No, it's fine. I did say we would take some questions. I have a few questions here. Well, the first one is for Sonia. How can friends and family support you and your family after this kind of loss? What has been most helpful in your healing? Or this is a similar question, but a little more specific. What was a helpful phrase or gesture that sticks with you until today?
So my experience was I really did not get a lot of comforting words. I got time heals all wounds. You'll move on. These things that were very triggering. I actually wanted to punch people in the face.
Did you get God has a plan?
Yes. They're in a better place. They're, very, and they don't understand how hurtful that is, and I mean, also things like, I know how you feel. I know how you feel. You don't know how I feel. Listen, I think a much better thing to do is say something like, I think you said this before. I don't know what you're going through, but you mean a lot to me. I care about you, and I want to be there for you in any way I can be. And don't be insulted if they don't text you back right away. You just consistently be there, and show your support.
Even when they are not responding.
Right.
They don't respond to the text them again. I'm here for you. What can I do to help? Making dinners?
was
offering to
insulted. I
take care of the
didn't come to
kids?
Bar mitzvah 3 weeks later.
Okay.
And things like that.
It's unfortunate you have a longer list of the don'ts that you've
I do.
experienced. Right,
But I
but
also, listen, I also retreated. I also went into my own brain. I went into so I think that was part of it also, where I didn't express maybe as much as I should have and reach out as much as I should have, or I don't know.
right, but even when you retreated, you would have liked your friends to stick there and keep texting you the Shabbat Shalom or the checking in
Well,
on you.
you
and
remember
being-
who did,
Yeah, because it makes a difference,
You
even
remember
when
who
you don't
did.
respond.
right? You remember
Yeah.
who did.
Can I offer a do?
Yes.
Okay.
Yes, last comment, 30 seconds, go.
Um, People believe that with the griever or bereaved, that they should not say anything about the deceased. It's a mistake. We want to know that our person who has left this physical world is still alive. So when you tell me I went to her grave today, I thought about her when I passed by a store. I still remember such and such. Today's her birthday, such a beautiful day, such a beautiful child. We want to hear those things because that reminds us that they're still alive.
But I also think some people think that if they say their name, you're going to be reminded that it happened, and you're not. We remember.
Right. And you want to remember the names of the good things that they've done, not just the past the cemetery, but I remember when we were walking and she was hugging the homeless. I remember when we made sandwiches for people and all the good things that they did. Okay, I'd like to thank Shalom and Sonia and our professionals as well. Turn it over to Dr. Jan Muscan.
Thank you so much for that incredibly moving and impactful presentation. I know that it couldn't have been easy. And thank you for allowing us to know Gila, Alea Shalom, and Rachel, Alea Shalom. They've already impacted our lives and seared in our memory. On behalf of the university, I want to thank all of our panelists. For those of you who I haven't met yet, Yael Muscat, Director of the Yeshiva University Counseling Center and Dean of Mental Health and Wellness. I'm also a proud alumna of Yeshiva University's Stern College for Women. My team and I at the Counseling Center support all Yeshiva University students, undergraduates and graduates from all walks of life, facing a myriad of challenges, and this issue is incredibly near and dear to our hearts. We provide individual therapy and psychiatry, as well as referrals and outreach events for students, and all of that is free and confidential. So when talking about access, I think that that's important to know about. We're very grateful for the university. And thank you all for coming out tonight. The event was co-sponsored by the Yeshiva University Office of Alumni Affairs, the Ferkauf Graduate School of Psychology, the Wurzweiler School of Social Work, and my office, the Yeshiva University Counseling Center. Now, I want to sincerely thank Ruth Tepler-Roth and Dr. Philip Roth, who are with us tonight. The Roths lost their dear son, Jonathan, to suicide. And we have gotten to know and learn about his memory, and he was an incredibly special person. I look forward to learning more about him. And since then, they've been outspoken advocates for mental health and suicide awareness. They generously support the Counseling Center this year and have allowed us to provide many programs for our students that we wouldn't have been able to have otherwise, and we're extremely grateful. And the students have really responded to them. If anyone here is interested in supporting the Counseling Center, the Ferkauf or Wurzweiler graduate schools, or the university, or even supporting another program similar to this one, please see Lauren Leibowitz or Galit Reichlin. Lauren and Galit, please raise your hands. And I also want to thank Beth for all of her hard work. She's not on this list, but she should be. This was actually something I think in her mind a little bit. Events like these support, they really support, they are a support and help us largely to make our work possible. And now our final speakers of the evening,
Ruth Tepler-Roth, and Dr. Philip Roth.
Oh, we have to.
Oh, it's on. Hello. Hi, so we're in the wonderful position of being between you and dessert and leaving. We're gonna do our best. Thank you so much for the introduction, and thank you very much for hosting this program and keeping this topic at a priority issue university. We're very grateful for that. And it's really very important to us. I'll say that I never imagined, never even understood slightly that mental illness had any relevance to my life until July 20th, 2012, when I found my son in a pool of blood after what was one of his suicide attempts. And to me, people who were mentally ill were those people on the subways, people who talk to themselves, people who talk to some imaginary person. I just had no clue. And why didn't I have a clue? Well, my son was captain of the wrestling team. He was champion wrestler. He won actually here at YU. He won the Wittenberg Championship. He had many, many friends. He was, he had a 398 index at school. He was very close to us. You know, I used to actually say to myself, how is it possible that I have this great kid? You know, wow. And, you know, he was a little bit anxious. So being very cautious parents and proactive, he was about 15, sophomore, and we said, okay, he's a little anxious. Let's have him see a therapist, you know, somebody that he could talk to and feel okay about. And, you know, that was fine. And then we started noticing some out of character behaviors when he was a senior. All right, so never having talked to his therapist, all of a sudden I called up and I said, you know, hi, this is who I am. I'm Jonathan's mom. And I just wanted to tell you, I don't know, like he seems to have suddenly out of the blue developed this intractable interest in drugs. I'm a child of the 60s. I know about drugs and experimentation. Oops. This is not that. This is something different. And okay, being a very responsible therapist, he of course had to assess the situation for himself. After all, I could be nuts. You know, I could be an overbearing, crazy mom. And then time would pass and he would say, no, it's okay. Time would pass and I would said to him, I noticed some very weird, like all of a sudden he'll be speaking really fast and pressured and he won't stop talking. And that's happened a couple of times. I don't know, it just seemed weird to me. Of course, again, I'm told, no, it's okay. I said, he seems to have gotten a couple of unsavory friends. I mean, this is real. I'm telling you things that I called about. That was another thing, unsavory friends, that I don't know. My husband and I are a little concerned about this. Or, you know, he doesn't seem to be sleeping, or all of a sudden he doesn't really care about what, you know, this kid who was in shape, look, he doesn't care about that anymore. Like what? And how come you don't know about this? And I have to tell you. So I was getting a little aggressive, but at the same time, each time I was told, no, listen, what is he, 18, 19? I mean, come on. He's a great kid. He's got some anxiety. And I was delighted to hear that. Thrilled. And I will tell you, it didn't just happen with this one therapist, because after one incident where we said, this guy obviously doesn't know our son, we tried another and yet another and another. And I will tell you that my son was so great that he fooled them all. The only one who I think got it right was the one who said he had bipolar disorder after he slit his throat and he was recovering physically. And this was the psychiatrist who he couldn't talk to her. He was in the throat, he was in an unfamiliar situation in the hospital and he was afraid. And so it was triggering to him and he had to write to her. So he must have been totally inappropriate. And she said, he's got raging bipolar disorder. But then of course he was discharged to the psych unit And there he was totally different than all the other patients. And the psychiatrist there said, no, he does not have bipolar disorder. He's got a little anxiety. So anyway, this is our saga. And I would say that, you know, every patient is different. Look, my husband and I knew instinctively, you know, when I turned 18, I'm the daughter of Holocaust survivor parents. I knew I had to marry somebody. Well, first of all, the whole family got involved. I'm 18. Oh my gosh, we got to get her married, you know. But I knew intuitively that I needed to marry someone with a similar background because I knew my parents were so off base in a certain respect. It was so much a part of me. I knew someone else who had that experience would understand me. And so sure enough, here we are. But his parents' Holocaust craziness and my parents' Holocaust craziness were different kinds of Holocaust craziness. And the same thing with every patient. I mean, you heard, you know, Rabbi Hammer was saying about his daughter had these triggering events. Well, you know, I was the director of a rape crisis center. I myself, unfortunately, was sexually assaulted at age 10. You know, it was a terrible experience, but I'm here to say I've had a very, other than my son killing himself, I've had a very wonderful life with wonderful children and a wonderful husband and a wonderful family. So what is the difference? Is it generational? That Bila Aleha Shalom, this beautiful light of a young woman reacted in her way and I reacted in my way? I mean, who knows? It's individual. So if I had to look back on my experience now, what would I say? I would say, you know, I didn't know the signs, as Rabbi Hammer said, but I sort of did because I did call. So I was hoping to be told it's nothing. And I would say, I wish that the therapists paid a little bit, I don't want to say paid more attention. They did pay attention to what I said, but then they had to rule it out, and they did. But you know what? You've got to work with the parents whenever possible. And you have to take what they say really, if you can't leave any stone unturned. And when you assess and you discount the issue of what the parent is saying, don't let it go. Because the parent is seeing their child in real time, in real life. You are seeing this child 45 minutes or an hour, once a week, in a setting where they feel comfortable and safe and good. And there's a world of difference there. So my message would be, not only don't leave any stone unturned and keep asking but keep asking the questions about those things that the parent is telling you. Just because you don't see it that one time, you may very well see it. And, you know, we had Jonathan for another 5 months after that very violent attempt, which he was miraculously survived. And we lost him in December. And he was determined. I understand everything that was said here, the pain. He just wanted to stop the pain. And I'm very fortunate that the last word, and I had no idea that very night. I remember talking to him. His last words to me were, "Oh, good night, Mom. I love you." And I went to my husband. I said, "I think we are turning a page." Well, yeah, not exactly the page that I thought. But that is the message that I would say for therapists, for parents. Parents, trust yourself. Love is the way you love your child. Don't hope to be told no. You keep hammering away. If you don't think you're being paid attention to, that's a sign that you got to switch. And to therapists, I would say, don't stop. Just because you don't see it that one time in this artificial room that you're in with this patient who thinks you're great and who you have a relationship with, keep going over and over and over. And with that, I will pass it over to my husband.
You would think after 48 years that I would know not to speak after her, but I'm going to try to muddle through as best as I can. First of all, as a parent survivor who lost a son a little over 11 years ago, I want to echo the thanks expressed to the organizers of this event tonight. It's very impactful. It's very impactful to hear the words of survivors It's very impactful to hear the words of therapists who are on the thick of it all and are on the front lines. Now, in my daytime life, I lead a department of pediatrics. It's a large department in a New York City hospital. My own specialty is neonatology. It doesn't take great acumen to see that the 2-pound baby in front of you needs some acute intervention. You look at him and you say, there's things we need to do. What I lose sleep over, what I worry about are the pediatricians in my department or the general pediatricians seeing healthy children every day of the week. And I worry amongst those 100 healthy children, do you catch the one who's not? Do you catch the one who has significant pathology? And as clinicians, and I'm sort of melding my parent hat and my clinician hat, as therapists, as frontline people, listen to your clinical instincts, listen to the things you're hearing, and don't just write them all off as being the same as the pack. It's a really critical thing, and you have that gut clinical understanding sometimes. Don't ignore it because you could miss something very vital. I'm also involved on a daily basis on something that people talk about called confirmatory bias. And so frequently we get patients in the hospital and they come prepackaged with a diagnosis, a bunch of tests have been done. And when we're teaching people, we talk to them and say, what doesn't fit here? This does not sound right to me. And they all look sort of mystified at me. What are you talking about? I said, this does not fit. Think it over. And so we tend to cling sometimes to the things that confirm that initial impression, what we've been told already. After all, a respectable colleague came up with this answer. And so I urge you all to give every patient a fresh look. You're going to be called upon sometimes to render another opinion. You may be the therapist who comes after the therapist that didn't work out. Really be very mindful. Don't fall prey to that trap. So again, I want to thank you for listening to us all tonight. I think, Ruth and I have sat in those chairs that Sonia and Rabbi Hammer are sitting in right now. And so, what you had to say, I'm always affected. I could hear everything you were saying about the crazy things that people said to us when we were sitting Shiva and everything else. And so, but be strong, keep on doing it. There's a lot of people out there who can make an impact and we have to help them do it. So thank you very much.
Dessert.